Good evening, ladies and gentlemen. I see straight away one hand being up, Dr. Sridhar. Uh, can I know if you have something to say, please unmute yourself and say whatever you have to say. Otherwise, kindly bring the hand down, Dr. Sridhar. All right. You're not seeing any gray squares on the screen, are you? Are you seeing any gray screens, gray squares on the screen?
No, sir. It's
Fine.
all clear. Yes.
All right. Good evening. I'll have to lower the hand here. Yeah. Okay. Good evening, everybody. It's very nice to see all of you here.
Good evening, sir. And thank you, sir.
I must thank Saptagiri Institute of Medical Sciences, Department of Surgery, headed by Professor Ramesh and Professor Kalaivani, one of the surgeons there, one of the unit heads there, for giving me this invite. I have always enjoyed discussing things with the youngsters. I personally have been a teacher for the D&B stream. I have never been in a medical college, but we are very active in the academic field, and it is indeed an opportunity which I cherish to interact with all of you. But please note the word is interact, which means that I should not be talking just by myself. I would like all of you to actively participate in form of questions, comments, and discussion where even disagreement is acceptable. All right, so please bear that in mind. Please note this email address, klakshman58@gmail.com. Anything you need, any questions you have on any subject, surgical subject, not just research and journal clubs and the like, whatever questions you have or whatever help you need, feel free to write to me, and I'll hopefully be able to help you a little bit. What I plan for this evening is to tell you what a journal club is in the first instance, and then to try and explain why we need it and how do we go about it. This is the crux of the matter. And then I'll give you a brief example of a journal club, the way we do it in our institution, in Saga Hospital, where we train our youngsters to, from the time they start our course, the D&B course, we train them to do it the way which I'm going to explain to you. And this is pretty much an international way of doing it, and accepted way. And you will find that when you go and search on the net for the way one conducts a journal club, you will find a lot of agreement with what I'm going to show you in the next perhaps 40-45 minutes. A journal club is a conventional teaching tool. You're all familiar with many tools, the bedside clinics, which is perhaps the most common and the most commonly and popularly used teaching tool, subject seminars, grand rounds where several unit heads get together and discuss things, multidisciplinary meetings where different departments, radiology, medicine, interventional radiology, all different departments, oncology and things like that, they get together and have discussions on cases, morbidity and mortality meetings where we dissect and understand and learn from the complications and the deaths we might have had in our work, group discussions done in many departments and in many aspects of surgical teaching, but perhaps very useful in discussing ethical matters. If you're looking at ethical matters, I think didactic lectures are of very little help and group discussions are very useful. But our focus for this evening is a journal club. Now, before we get into the nitty-gritty of a journal club, we should look at journals. All right. And I took a very small poll 10 minutes earlier, and I found that the majority of the people were not reading articles in journals even once a month. Okay. And nothing wrong in it. You can start doing it now. But then it tells me that I was right in putting the subsequent slides on this talk today, because if I had gone straight into the journal club discussion, it would have been a little bit of a big jump for many of you. All right. So journals are an integral part of learning and practicing surgery. I say that because even practicing surgeons need to read journals on a regular basis, more so postgraduates. In fact, perhaps the only people who need not get into journals are undergraduates who perhaps should be happy with textbook information. Please understand, I'm in no way taking away the importance of textbooks. They're very important. You must read your basic and reference textbooks, but you must go well beyond it if you want to be a good surgeon and a good postgraduate with good knowledge. Textbook reading is not enough for several reasons. The information you get in it is at least 3 to 5 years old. By the time the newer developments get a show or get to be discussed in a textbook, it will be about 3 to 5 years old. You can't afford such old information. It is usually opinionated. It's written by one or several authors. If it's a one author person, I'm not taking away the importance of senior surgeons writing books, but even if I wrote a book tomorrow, it would be my opinion, and it would be biased. There's no way an individual can get away from bias. But as a student of surgery, you cannot afford to be biased. Kalavani, can I request you to keep muting everybody? Keep mute. They don't understand.
I'm doing it.
I made you a co-host.
I'm doing it, sir.
So just keep muting everybody. Yeah. And
I'm
those
doing
who want to talk can unmute themselves and talk. Okay. So there will be a bias in something that's written in a textbook, even if it's a multi-author book. Each chapter is written by an author, and that author's skewed view, if you want to call it that, biased view, will get into it. And it is not really peer reviewed. Very important people are asked to write books, and nobody peer reviews a book. And so if you want to know the real surgical controversies, real issues which are discussed threadbare and which are recent, you need to look at journals. And so that is where you need to start developing the habit of reading the journal at least once or twice a week. And as Kalavani mentioned in the introduction, today surgical practice is evidence-based. And if you want evidence, you have to have journal articles supporting your evidence. There are many kinds of articles. I'll talk about it later. So important thing, again, as I said, if you want to get out of this deficiency of a textbook, you need to look for proper evidence in what are called peer-reviewed index journals. I'll tell you a little more about it in subsequent slides. So you have peer-reviewed journals, you have peer-reviewed websites. For example, Medscape is a peer-reviewed website. There are many such websites. So information you get from those websites would be acceptable, would be believable. But please note that if it is not peer-reviewed, anything and everything will go on the net. And so do not swallow things that are told or written on the net. It's very, very important that you look for what is called peer-reviewed sites and peer-reviewed articles. Now, if you open a journal, there are many, many types of articles and types of literature in the journal. Okay, you will commonly see editorials where a senior doctor, academician is asked to write 1 or 2 pages on the current topic. There will be reviews and meta-analysis where several original information from several original articles are collated, are put together, and a summary is given of that. That's a review. You have original articles where the original research work done by an individual or a group of individuals is put in print. You have case reports, short reports, which are not necessarily cases, but other surgically relevant issue that would be given as short reports. For example, one of my papers, a short report on conducting a web-based conference, was published in the IJS. It's related to surgery, but not actually direct patient care. But I wrote about my experience of conducting our mid-cons in the state, and how to go about organizing a web-based conference. So that was taken as a short report. You can have little short reports or papers on surgical technique. You can have an interesting surgical image, a photograph of a rare condition, or a photograph of a good investigation, for example, an MRI or a transrectal ultrasound or whatever, and letters to the editor where people can express their views on the published articles. I'm just giving you a very brief overview of what you find in a journal. But as a postgraduate, I would recommend that you read all the editorials, read the editorials, read the reviews, and read some original articles. And you can't possibly read everything. So I would ask you to request you to focus on editorials, reviews, and relevant original articles. These are the things that you should do. And as far as the journal club is concerned, the original article is all that you need to focus on. You can have journal clubs on reviews and meta-analysis and other things like, conference reports or consensus statements and things like that. But for all practical purposes, I would strongly recommend that you must use only original articles for your journal club discussion. Why? I'll tell you as we go by. Now, you must also know what the components of an original article are. It has to follow a standard pattern, and that pattern is this: abstract, which gives you a summary of the article. Most people read abstracts first, and if they find it interesting, then they go on to read the full article. In the article, you will have an introduction, you have a patients or methods. If patients are not discussed, but something else is, it's called materials and methods. You have a results section, you have a discussion section, and you have conclusions. And after the conclusions, you have acknowledgement. You thank people who have helped you in doing that study and bringing that paper out. This is something I want you to bear in mind, because this understanding and internalizing this structure of an original article is very important when you discuss the paper in a journal club. All right, you will know when I come to that stage. Now, the primary purpose of a journal club is to learn and teach others critical appraisal of a paper. Okay, when a paper is published, remember I told you peer review, so it is seen by experts, but still you do not take what it says at face value and swallow whatever it claims. As an individual surgeon, as an individual student of surgery, you have to critically evaluate that paper. That's called critical appraisal. And the primary job of a journal club is to teach you the skill of critical appraisal. And when you have gone beyond the student phase, when you don't have to write exams, you still need to critically appraise a paper, because it gives you evidence for your practice. And so you need to understand incisive analysis for your practice. Is what you're doing, is it correct or not? If something that a paper says is different from what you're doing, should you change your practice based on the results of that paper or the conclusions of that paper? That is something that you have to know. And so doing a journal club, either in a group or just by yourself, is an activity for life as a surgeon. And very importantly, for academicians and those who are interested in doing research, doing studies, and writing papers, a journal club information helps you to design protocols. Why? It gives you the subject. There are some doubts coming out of a given paper, a published paper. You address that doubt, do research, and write it. That becomes a new paper. And that is how science progresses. So a lot of things that I have done have directly come from reading papers and analyzing them. And it has helped me design protocols. If some paper had a poor protocol, if I critically analyze it, I can improve on the design of that study and give a better protocol. Somebody will read my paper and even improve on it, and even better protocol will come out. And that is the way journal clubs and critical appraisal of papers help you design protocols. But that's why you need a journal club. It's extremely essential part of surgical training. And all of us as postgraduates must learn about critical appraisal in a journal club, so that it helps you for the rest of your life, even if you're not a researcher, as I told you, even if you're a practicing surgeon, to know what is good practice, what is evidence-based practice. You must learn this skill in a journal club. So critical appraisal has a few questions, 10 or 12 questions that you ask of a paper. All right. So that's what I want to tell you. And before, and only after I have mentioned about critical appraisal, am I going to actually get into the nitty gritty of conducting a journal club. This is a big definition which none of us need to mug up or learn by heart. But what a critical appraisal does is to assess the validity of the data. Okay, is it a valid set of data that the person has published? Is the reporting complete? Many people suppress data to get positive results. So there are ways in which you can find out whether such suppression has occurred. Are the methods correct to answer a research question? Every paper, every research project, every thesis, for example, that you're going to write will have a research question. You ask some question to fill the gap in the existing data. So that research question has to be answered by a specific kind of a study. So is this the correct kind of study that you're doing, is that they have done? All right. And are the conclusions based on the report or the results of the study? Okay, I'll come to that when we go on. And I keep saying every surgical society meeting, I get up and say your conclusions are not supported by your data. So somehow we ask one research question, have data for one conclusion, but we want to give 5 conclusions at the end of the paper. That is not at all correct. So what you have to do is have one good question, have one strong answer with strong data. And that's a much better paper than a paper with several conclusions without data. So that is something which you need to do. And then always look at the ethical standards. Everything that we do must be ethical. Practice, research, writing, you name it, it has to be ethical. And there are standards, and we need to appraise whether a given paper meets those standards. So put it in a nutshell, you evaluate the strengths and weaknesses of a paper. You assess the appropriateness of a study design. You see the metrics or the kind of tests and results or the measurements that are used in the study. You must know a bit about statistics to know whether the correct statistical tests are employed, and then you must evaluate the conclusions that are drawn. All right, and then look at the ethical standards. Now, for the beginners here, do not expect you. We do not expect you to do everything on day one. If you learn the nuances, the fundamentals at the end of 3 years of your MS, you have done very well, because the more you do it, the better you get at it. And do not expect to have all the answers in 1 or 2 journal clubs. But the attempt to learn must be a continuous process throughout your studentship as an MS or a DNB candidate. And never take journal clubs lightly. People just go through it and, in a mechanical manner. Don't do that. Please understand and internalize what I'm going to say in the course of the next half an hour, 40 minutes, and try and walk in that path, so that after a few journal clubs, maybe 15, 20 journal clubs, you will have some grasp of the subject. Now, I told you that there is a research question in every research, and that question has to be answered by a specific kind of a study. For a given question, there is a proper study that one has to follow. Right? All research studies in surgery or any other field come under 2 broad groups: descriptive and evaluative. Descriptive is where you just describe what you see. How many people, for example, with a goiter in your area have iodine deficiency? I'm giving you very simple basic. It will be many such things. Descriptive study. There is no intervention from you. You are not intervened anything. Something is there, and you have collected data and described it. That is a very valuable data set, and don't underestimate it. But many things which are perhaps a little more directly clinically relevant are evaluative studies. So you intervene, you give a medication, you do a surgery, or do 2 types of surgeries for the same underlying condition. Okay, open surgery versus laparoscopic surgery. In laparoscopic surgery for a hernia, for example, tap versus TAP, and compare the 2. And when you do that, that is an evaluative study. And then if you randomize, I won't go into the details of it. That's a separate topic by itself. You have to have controls because you cannot have a bias in this. You cannot have what are called confounding factors, which are factors other than your intervention, which may have an effect on the outcome. So you have to control for that, and then you get a good study. So when you have an evaluative study in a journal club, your job there would be to know if the confounding factors are addressed and nullified. If there are a lot of confounding factors, then the results, the conclusions from those results will be not very dependable. Now, the next two slides are going to confuse you, but I'm just remember the terminology, go home and read up about it, and over the next 6 months to 6 months to 12 months, you'll perhaps understand it. But I put up this because I want you to just understand the terminology. Primary literature is where raw data is collected, either in an evaluative study or in a descriptive study, and a paper is written about it. All right, that is a primary literature. Now, if you have, I told you, certain kinds of questions need certain kinds of studies. I'm repeating it 3 times because that is something which is fundamental in assessing the veracity of a journal in a journal club. If you're looking at treatment efficiency, you must do what is called a randomized control trial. In a diagnostic accuracy, need not be very controlled. It need not be randomized. It has to be controlled. Slides are not moving. I get a message. Why is that? Did the slide move now? Kalavani, can you tell me, please? Did the slide move?
There's no problem. You still haven't finished that slide.
Okay. Okay. One other thing may be that the person's net may not be very strong. Yes, sir. Okay, now that, thank you. Okay. Sorry. So if you're looking at treatment efficiency, you do a randomized control trial. If you're looking at diagnostic accuracy, you're doing a control trial. If you're looking at a prognosis, you're doing a cohort study. I will not go into the details of this because I do not expect you to understand all this at this stage. But all these studies, RCTs, control trials, cohort studies, case reports, short reports, these are all primary literature, okay, because you are collecting raw data. Contrasted to this, you have what are called secondary literature. Secondary literature can be discussed in a journal club, but I think that is for postgraduates, because in a secondary literature, you're actually assessing not only the veracity of the primary literature that it contains, but also the veracity and the appropriateness of the way in which the data is pooled. So in a secondary literature, you can guess now that it pools or collects data from several studies of primary literature, because it gets larger numbers. If somebody has done a randomized control trial, you can't do it for thousands of people. Okay, so if everybody has 100 cases of RCT, if you have 10 similar RCTs from 10 different centers, you will have 1,000 patients, which is a lot more valuable. So you collect the data from all these 10 centers, have 1,000 patients, and either give a systematic review or a meta-analysis. How you do it can be critiqued in a journal club, but that's not for MS and DNB. That we will discuss later. So I just want you to understand that secondary literature is literature where data from the primary literature is collated, analyzed, and reviewed, and a document comes out. These are very important because these form the highest level of evidence. So in your practice, if you want to look at a question, you really have to look at systematic reviews, meta-analysis, and practice guidelines. Remember that, practice guidelines. These are the secondary literature that we all follow as practicing surgeons, and as postgraduates also, you must have the skill to take out, read, and understand these things. Now, as I said, the evaluation tools for all these different kinds of studies will be a little different, but all of them have a certain fundamental set of questions that have to be asked. So I'm going to focus on these fundamental questions. All right, so I'm going to stop here a little bit, ask for questions and comments. Do you have any questions? If you do, please unmute yourself and ask me, or if the seniors here have any comments and things, most welcome. All right. I have this very bad habit of asking you questions if you don't ask me questions. All right. So I'm going to, if you're not a postgraduate, please say so, because from the names, I probably wouldn't be able to recognize, but I see the name Prakriti here. Prakriti. Prakriti, can you unmute yourself and answer me, please? Unmute yourself. Are you there? All
Yes,
right.
sir.
What is the difference between primary and secondary literature?
Uh, so in primary literature, it entails a treatment plan given from the type of study that gives out.
You have a bad cough. I will excuse you. Just mute yourself, Prakriti.
She's one
You are in
person
trouble,
in
and I don't want to trouble you further.
she's one person in quarantine, sir.
Yeah. Rinisha,
She also,
can you?
okay.
You are also there. Zaiba.
Zaiba is fine.
All right, Zaiba, go on. Tell me the difference between primary and secondary literature. Unmute yourself, please.
Zaiba,
She's not there. All right. Shreya, can you unmute yourself, please? And are you there? All right.
Zaiba, Shreya,
Is it that
Shifa.
they have just logged in and not bothered to be there? All right, let me not waste any more time because
Shifa,
this
Shifa.
experiment has failed. All right, not to worry. Let me proceed. I told you that when you're doing a critical appraisal of a paper, there are several important questions that you have to ask. Okay. Now, is the study question or research question relevant? Is the first thing. Okay. So when as clinicians, when we have a journal club, there are many fundamental science questions, uh, like the DNA studies, the protein literature and things like that, which are interesting, which are important, but as a clinician, that's not the main thing. We would be looking at relevant questions. It could not be um, a very big thing. It could be as simple as saying, is a Rayleigh tube necessary after a laparotomy? Okay. Second, should we put a drain after a cholecystectomy or not? These are the kind of questions that are simple questions which are clinically relevant, which we need to address and get studies, read about them, and as Kalayavani said in the beginning, conduct them yourself, that those kinds of studies yourself in your thesis or in your clinical research, so that we produce data from this country. We do a lot of cases, but we have very little data from India. So we need to do that. Okay. The second thing is, does the study add anything new? Please understand that science doesn't advance by leaps and bounds. It's always a very, very small incremental information that most of us produce. Very rarely, once in 10 or 20 years, some big leap takes place, but it's rare. Okay. So what happens is that you have to have something that is new. And remember very clearly that a research question in a new cohort. A cohort is a group of people. So suppose you have a question that is answered in the US or in Europe, but you have no Indian data. That is something new, because the new thing there is the Indian data. So you can do a similar study in India and produce Indian data. Even that becomes new. It need not always be something, as I said, path breaking. Okay, what is the type of research question asked? Now, this is where you need to know a little bit more about research. Is it an effectiveness study? That's one thing that most of us deal with in terms of medication and in terms of operations that we do. Is it epidemiological? Some of it can be epidemiological in surgery. And again, cohort intervention and outcome studies are also important, because effectiveness usually measured through randomized trials need not always be done. It can also be done through a cohort or a group of people. All right. This you may not understand at this stage, but you can correlate or match the research question with the type of study that you do, and then you will get the correct answer. Was the study design appropriate for the question? It is another way of asking the previous question. So if you have an effectiveness or an outcomes thing, as I've told you earlier, you need to have a randomized control trial. If it is a frequency of events, all right, then it will have to be an observational or a prospective study. Prospective study is study that you do starting at a given point and in the future following that afterwards. Retrospective is that you are starting the study at a given point and you're looking backwards, previous 2 years, previous 1 year, and see what happened to the events. Retrospective studies are always inferior to prospective studies. There are many reasons for it, but we will go into it at some other time. So the next question you asked, as I said, was that the study is whether the study is appropriate for the question or not. Okay. Is the audio any better now? Because I have a message here that the audio is lagging. Is it true for everybody? Because my bandwidth seems to be pretty good.
No, I can hear it very clearly, sir.
All right. So it may be actually the recipient's bandwidth. That's possible. Yeah. Okay. So were sources of bias addressed? This is an extremely important thing that you have to assess. As I said, as an introductory lecture here, at least the beginners will not be able to comprehend everything completely, but understand that this is something that you have to address. This is where you look at confounding factors. There are many kinds of bias. Okay. Selection bias, a bias because of confounding factors, a bias related to statistics. So you have to look at the possible bias for a given study and make sure that you address those things when you are assessing a paper. And one of the commonest things that happens is that certain patients are excluded. It may be by accident where the researcher is not aware of it, or it can be by design. Particularly in drug trials, it's very rampant that some of the unpleasant results which do not conform to the message that somebody wants to give, okay, those patients are excluded. And there are ways of determining whether such what I call improper exclusions are there or not. And that is through a flow chart like this. A classical flow chart for a randomized control trial is what is called a consort flow chart. So if you are looking at an RCT paper and critiquing it in a journal club, you first see whether a consort diagram is given or not. If a consort diagram is not given, there is something lacking in that paper. And always make sure that the protocol that was put out, which will be described in the materials and methods section, was followed properly. They would have said that this is the minimum, it's what's called a sample size. This is the minimum number of patients that we study. Did they actually have those numbers? Did they change the inclusion and exclusion criteria halfway through the measure? Was the intervention changed? Somebody starts off saying, I'll do the operation this way, I'll use this suture and this kind of dissection. Halfway through, they change the suture, they change the surgeon, they change the pattern of dissection. Those things are not acceptable. So you need to know that these are the things that have to be done. And of course, the duration of follow-up is very important. So when you are analyzing a paper in a journal club, you have to give attention to all this. And does the study test the stated hypothesis? I won't go into the details of this, but you need to understand what is a null hypothesis, understand what a significant level is. And I'll just mention about this post hoc analysis and then go to the next slide. What happens there is that suppose they have a protocol, they have a whole group of people and they expect a particular positive result, but they don't get it. So they're worried that their negative result does not get published. So what they do is, as an afterthought, that's why it's post hoc, as an afterthought, they start doing a subgroup analysis. And then they'll find some positivity in some subgroup of their total patients. And then they try to publish it. Such publication is not considered correct. And so this subgroup analysis, which is done as an afterthought, is not acceptable. As a contrast to this, if the subgroup analysis was originally envisaged and described in the protocol, then it is perfectly legal and correct. Statistical methods improved, performed correctly, very important. Statistics is a difficult subject. I think I saw Ramakrishna's name here. Is one of our leading lights in statistics. He written a book on it, and I always depend on him when I need some advice about statistics. It's a surgeon in Bhadravati. So note that you don't have to be a statistician to be good at statistics. So I consider him a motivating force for all of you. All of us must learn. We may all not become Ramakrishnas, but at least spend some time learning the basics of statistics. That's very important. Do the data justify the conclusions? I have mentioned about it. I won't repeat it at length, but please note that every conclusion in any paper, either the ones that you read or the ones that you write or present yourself, must be supported by the data in that study. Okay, that is very, very important. And are there any conflicts of interest? This is of importance of late. Is the author being paid by a given mesh manufacturer? Suppose you write a paper on a hernia mesh, for example. Is the author being paid by a company whose mesh he's promoting? Not that you should never be paid by somebody, but you must declare it. You must openly declare that you are a consultant to something, or getting money from somebody, or getting a grant from somebody that would have in some way influenced the study. So a critical appraisal is not only for students in a journal club. Remember that. I think all practitioners throughout life must be doing journal clubs or equivalents of journal clubs. It improves with practice. I told you that the first few journal clubs, the beginners who have just joined the MS or DNB may find it very very difficult, and they may not understand half of it. Never mind, keep at it, and by the end of the year you will be very good at it. That has been our experience in our institutions. People who have started as complete novices, by the time they come to the end of the first year, they can really give very important inputs in the discussion. It's best done in journal clubs, groups of people. Students are the easiest, but I have done journal clubs with little groups, 4 or 5 practitioners. When we didn't have the access to DNB course, or we were never in medical schools, 4 or 5 of us doctors would sit together and do a journal club ourselves. It helps design protocols, as I mentioned. And once you do a journal club and learn the critical appraisal, your writing style, your research style improves with time. And so you will have a higher chance of getting your paper published. All right. I will take a break again here and invite comments and questions. Any questions? Any doubts?
If not from PG, sir, shall I?
Please, please.
Which year of, which year PG should actually start off with journal clubs?
I think
There's always a confusion there.
I think first year. I have no doubt. In our DNB, we ask the first years to do journal club. What happens is that as mentors, when the first year we spoon feed them a little bit, quite a bit. In fact, we tell them this is the way to do it. Yes. We do everything for them, and they just present. Yes. And as they progress, they do more and more by themselves. By third year, they've done most of it by themselves. Yeah.
It will be good for them to learn how to learn.
Learn how to learn. Yeah. Yeah. And I'll tell you the mechanics. As we know, this is actually the conduct of a journal club, but without the background that I gave so far, which has taken us 40 minutes, you really cannot, understand the conduct of a journal club. Okay. Can I proceed?
No. All right. Questions from any? Yes, sir.
Any questions? I don't see any in the chat box either.
Nothing, sir. Marshall, right. You don't have any questions? Fine, sir. No questions.
All right. All right. Yeah. Now, this is very important. I think this is the crux of the matter in a journal club. I told you it's a conventional teaching tool and a group activity, but it must have a moderator and a presenter. The presenter is usually the PG. The moderator has a very important role to play, particularly when the PG is new. All right. So what he does is to practically supervise every aspect of the presenter's presentation. He helps choose articles. I'll tell you how to choose articles later, but beginners won't know what to choose. So I actually choose the article for our students, and then he checks the presentation that the student has made. In fact, we check it so thoroughly that we tell them step by step that this is how you do it, and they send it to us. Typically in our institution, they send it to us by email, and we correct it and send it back to them. And this happens 2-3 times before the presentation is finalized. And what is on the right of the side is very, very important. All right, I'll say that first before I come back to the presenter, because the presenter is the primary role. But this is important because participants are active participants of the journal club. They can never be passive. They must independently read and critique the article, which means that 4 to 5 days before a journal club, all the participants would have received the copy of the article that is being discussed. So it is the job of the presenter to send a copy. We send a PDF format of the article to all the people who are participants. So they must read and independently critique it themselves. And then they also do some collateral reading. It's not just you're reading only that paper. Similar papers have to be read to know what importance this paper has. And finally, the participants critique the presentation done by the presenter. That is the final responsibility of the participants. Okay, because every critique means a comment, the good points and the not so good points about the presentation. Critique of an article means the good points and the not so good points of the article itself. So that critique is the actual learning process. How analytically you do it, how scientifically you do it, is the crux of a journal club. Now, the presenter is the most important part of a journal club. He chooses the article with the help of the moderator, of course, sends it to all the participants well in time. In our unit, in our hospital, it's at least 5 to 7 days in advance. Does the critical appraisal of the article. I'm sorry about the spello there. The critical appraisal of the article. He undertakes collateral reading. He reads 3 or 4 more similar articles and gets information from them and prepares the presentation. All right. How it is done, I'll show you in the example. Okay. Now, the next thing is, how do you choose an article? This is again important. I told you that you must try and do practically only original articles. Do not choose review articles and editorials and things like that. It must be preferably less than 2 years old, but if you have something very interesting, you can go as far back as 5 years. And beyond that is not the preferred thing for a journal club. It must be from an index journal with a good impact factor. Some of you may not know the meaning of these two words, which you will know in the next slide. Generally, it must be clinically relevant, impacting on practice. After all, we are training to be clinicians. We're not training to be fundamental research scientists. So it has to be clinically relevant. It has to be an original study. I told you, original article, preferably a randomized control trial. But it's very difficult to do RCTs in surgery. There are many. We have done some, but try to do it. But if you don't have a RCT, a good large cohort study, even retrospective, preferably prospective again, even those are acceptable. But avoid case series, case reports, and as I said, definitely review articles. Retrospective studies, if it's a large number with some important message, can be considered and critiqued in a journal club. I told you 2 words: impact factor and indexation or indexing, whatever you call. An impact factor is this. This is a formula. Total number of times an article from a given journal is quoted by others in the previous 2 years, divided by the total number of articles in that particular journal. That is an impact factor. The higher the number is, the better it is. All right. Index journals are those where these journals are listed. These are called indexes. Now, NMC is very clear. There are only these 5 indexes which are accepted for your publication. If NMC has its rules that you must have so many publications. Those must figure in one of these. Those journals must figure in one of these indexes. On the same count, those that you read and use in a journal club must be from one among these 5 indexes: the PubMed, the Scopus, Directory of Open Access Journals, Science Citation Index, and the Embase. There is another index called Index Copernicus, for example. It is not recognized by the NMC anymore. It was recognized by the previous MCI, but that has been taken off the list. So note where your journal article is from. Also note what the impact factor of the journal is. Need not always be great, but it is good to have something from a good impact factor journal. All right. So the presentation itself, I have found many people just cut and paste sections of the article in your presentation. That is an absolute no-no. Okay. What you have to do is read the article, digest its contents, and put your presentation in this manner: a brief description of the source, relevance of the subject, and the research question asked. Describe each section with gaps in between. So you give an introduction and then go to the research question. Say, this is the research question. The next part of your presentation will be the patients and methods. Give a gap. Next, results. Give a gap. Next, discussion. Give a gap. Then conclusion and final critique. These gaps are meant for critiques. Okay. So what you do is give the summary of materials and methods, or patients and methods, the procedures, the intervention and lot, and give a gap and ask for a critique from the audience. The audience is your journal club members. And as I told you, if they are good members, they would have done their critique themselves. So they give you all the critique that they have. And after all the audience have given their input, then you give your critique. That will be the final critique of that section. Then you go to the next section, which is the results section, likewise. So after each section, like patients and methods, results, statistics, conclusions, you give a gap and ask for a critique, and you give the critique yourself. Many times, by the time you give the critique yourself, the audience, if they are very good and they're actively participating, would have mentioned many of the points that you would have put on the slide. So your slide, your critique slide actually becomes a summary slide. The critique must include both good and bad aspects of the study. I have now stopped using the word bad. Instead, I use not so good, because I don't think bad is a good word. The pun not intended. Okay. So that is very important. Always touch on ethical aspects, touch on conflicts of interest as well. That's a part that you have to understand. Okay. And this is very important. After everything is of the paper itself is done, and after the final critique is discussed, the presenter gives 1 or 2 slides of collateral reading. Similar papers which are given, perhaps results which agree with this paper or disagree with this paper, and then compare the results. And final and very important, final, last but not the least, is the commonly used phrase for this: does this apply to our situation? For example, a paper that you may be reading out of interest, talking about something in a very advanced methodology with big series of equipment that you don't have in your hospital. It's good to know, but it's not applicable to your situation. And if it is applicable to your situation, would you change your practice because of this? You're doing something and this paper says I would do otherwise. Would you change? A discussion must take place. That is actually the whole purpose of a journal club. Apart from the technique of critiquing, learning critiquing and learning evidence, what you have to finally analyze and understand is whether you should change your practice based on the message given by this particular journal. Okay. So in the last 10 minutes or even less than that, as planned, I will show you an example, not a complete one, but I'll skip slides because it's only an example of a typical journal club presentation we did, I think, a year or year and a half ago in Sagar. Okay. This is one of our DNB students was since finished and is now practicing or his job in Calcutta, Saurav. And we did a journal club. I was the mentor, and it was about the closure of a defect during laparoscopic umbilical hernia repair. It was an RCT. Okay. And it tells you who the authors are, where it was published. It was published in British Journal of Surgery with a good impact factor. 5.8 is a good impact factor. The highest impact factor is JAMA surgery. Okay, JAMA surgery has an impact factor, I think, which is 8 point something or 9 point something. And this was about 2 years old. We did this in 21, I think. And the paper was in December 2019. Sorry, it was actually published in February 20. Okay, accepted and published in February 20. So this is the paper. As you can see, this is a very clinically relevant topic. We do umbilical hernias all the time. Should it be IPOM or IPOM plus is the question. Should you close the defect or should you not close the defect? That is the question. All right. So there is an introduction which says, please note that this is not a cut and paste from the journal. He has given you bullet points, and he's given you what is it that is being addressed. He tells us that they're looking at the complications like post-op pain, readmission, surgical site infection, between closing and not closing the defect. That is the thing. Okay. And why is it important? Because there is conflicting data as of now, whether you should close or not close. And the hypothesis, we told you about a research question. The hypothesis is that closure of a facial defect increases early post-operative pain. Okay. Now, if the data agrees with this, then this is called this is actually not a null hypothesis. A null hypothesis should have been, say, closure of the facial defect does not increase post-operative pain. But this is the opposite of a null hypothesis. It doesn't matter. You can, as long as you have a set hypothesis, it's quite okay. So if the data proves this hypothesis wrong, it means that closure of the facial defect does not increase the pain. Okay, that is decided by statistics and the significant levels and things like that. So this is a very objective analysis with seroma formation and long-term recurrence and chronic pain. So it was a long-term recurrence as well. So he describes the methods. I won't go into the detail. And he describes the inclusion criteria and the exclusion criteria as defined in the paper. And then there are 2 slides because a long set of exclusions, and then he asks for a critique. This is a blank slide. At this point, the presenter says, ask the audience, what is your critique about the good points and the not so good points about this paper up to this point, which is up to the patients and methods section. And after that, he actually puts up his own critique. All right. And he does it point by point. First, for, that is the good points. Next, against, which is the not so good points. So he keeps doing this. It's a recent article, the relevant topic, the journal with a good impact factor, well-structured hypothesis, good selection of patients with a 2 to 6 centimeter defect. Because anything very big, you would not do a closure of the defect. You would do something like a mobilization of the transversus abdominis muscle, and release procedures, flaps and things like that. So it is a good definition of 2 to 6 centimeters defect. Ethical committee, and they have followed consort guidelines. RCT must have consort diagram, so they would have given it. Against it, which is not so good, sample size is small, and that was about the only thing that we could think. And we then go on to the study design, surgical procedures, and you will see that it had certain negative points. The defect size assessed clinically, we said 2 to 6 centimeters, but they had not actually measured it with a scale. There are methods of measuring a defect even laparoscopically, which they had not used. And rectus diastasis were included. You should not include diastasis in hernias, but in this case it was several such things. So these were the not so good points about this. Okay, and you can see it is a double-blind study, good randomization. There are ways to randomize that, done all that. So I won't go into the details, but I hope you get the trend to say that all the good points are mentioned, all the not so good points are also mentioned. All right, and then he shows the consort diagram to say that that's what came in there, and the critique of the results also given here. 14, and if you have a high recurrence rate, which is what is shown here, okay, 22 out of 38 patients, that's not a normal, that's a negative point. If you have 14 out of 40, even after closure, if they get a seroma or sorry, a high recurrence rate, 17 out of 78 and 14 out of 40, very high. So there is some question about the quality of the surgery done or the quality of data or whatever. So these are the things that it's sort of coming out in a jumbled manner. I won't go into the details of that. Okay, so discussion comes next, and there is a good point critique which says comprehensive list of limitations. Every paper will list its own limitations. Okay, I will skip through this. So the conclusion is closure of facial defect in laparoscopic surgery in an IPOM repair significantly reduced early seroma formation. Okay, that is what they concluded. And then you will see there's a literature. He has looked at the summary of other papers, and then putting all this together. Should we change our practice is the question. This answers here. So because of these limitations in the study, because of what the other papers say, the jury is still out if we should suture the defect or not, whether you should do a IPOM plus or just do an IPOM. As of 2021, when this was done, the jury is still out, and that is the conclusion, which means that those who are not closing the defect need not start closing the defect. All right, so that actually brings me to the end of my presentation, and I sincerely hope that you will have some questions or doubts at least now. All right, because if you're reluctant, as Kalaivani has said, if you're reluctant to ask questions, unmuting yourself, you're welcome to put your question in the chat box. Okay, or if I can invite comments from people, seniors here. Right. So if you have, Kalaivani.
Yes, sir, I'm asking them.
Yeah.
Marshall, are you there?
Yes, ma'am.
You are supposed to present this week. So clarify your doubts.
Yes. So good evening, sir. Sir, in conclusion, sir, should we cite the conclusion that the authors have concluded, or should we give our conclusion, like based on our critical analysis of the paper, that we either agree with the conclusion or disagree? Like that, should the conclusion be, or should we just
you must give the conclusion that the authors have given, and in the critique part, you may agree or disagree with it. But the conclusion in your presentation of a given paper must be the conclusion given by the authors.
Thank you.
Narasimhan sir, if you're still there, your comments, please. You may not be there now. Yeah. Srikanth?
Nothing to add, sir. Excellent.
Yeah.
But it takes time to grab each and every point.
Absolutely. As I said, if a good part of this presentation you felt you didn't understand, you're not alone. Okay. I was like that when I was a student doing my fellowship, but we all learn as we go along. It takes at least 2 to 3 years before you get somewhat good at critiquing a paper. So
when you are preparing this thing for journal, you should keep these points on the side and then practice producing this thing.
Yeah.
Preparing the paper.
Kalaivani?
Now, sir, there is the biomedical research course, basic biomedical research course has been made compulsory to all the teaching faculty and the students.
Yeah.
So probably if everyone takes up that exam, it is definitely a good, because there are some lectures on it where they make us understand on each subject, like how cohort and everything, they give everything in detail. Yeah. So because probably I have done, and few of us have done, and few of the students also have done, I find it little easy now to understand and so reproduce and all. Definitely, it has made a lot of difference.
I'm familiar with this course. It's a very good course.
Yes, sir.
My only comment is that it is done by epidemiologists, not surgeons. So you will find that it is very heavy on epidemiology. Clinical surgeons, they learn a lot from it. I'm not at all in any way, negative about that course. I think it's an excellent course. But then if you learn from that and then apply it clinically, then it will be a lot more useful.
Definitely, sir. We understood the concepts, we understood the definitions, and now it's easier for us to critically appraise our journals and our own journals.
Yeah.
We are writing articles. So PGs also have done. If you can just comment and PGs give your opinion and ask questions, it will be good. I don't see any PGs asking any questions.
Yeah.
Probably the first year PGs, I understand it's difficult, but final year PGs, at least something you should comment on.
There's
Arvind?
something in the box. What decides if a publication gets indexed or not? Publications don't get indexed. Journals get indexed. Okay, so there are criteria that all these good indexes, the 5 indexes that I spoke to you about, they have set criteria. And so they include or exclude journals. It is done every 3 years. And so it's not that once you get onto the journal that you're there forever. With our own Indian Journal of Surgery, unfortunately, for 2 or 3 good reasons, we got disqualified from the Medline. It is indexed in Scopus, so it is still official, but it got disqualified from Medline, for example, 3 years ago. And this year they are applying again to get back on to the Medline index. That is the father of all indexes, the Medline PubMed. Yeah.
So as of now, it's Scopus Index, sir. Even
Scopus
that
only.
wasn't
It
there
is not in
last year.
PubMed. It is in Scopus.
Okay, thanks.
Yeah.
Any other comments and questions from PGs or any faculty? No
Right.
questions
If
from
there
anyone,
are
sir.
no more questions, I would really like to thank all of you for attending this, and thank Saptagiri Institute of Medical Sciences. There is a. Oh, it's good. Okay, it's a comment. Yeah. SIMS and the Department of Surgery. Professor Ramesh, Professor Kalaivani for giving me this opportunity. Thank you. Thank you very much.
We thank you, sir, from the Saptagiri Institute. We wholeheartedly thank you for this effort. I'm sure something has gone into everybody's head.
Oh, I'm sure.
And it has stimulated them how to go about. And from here, probably the faculty will take over and do something.
Yeah.
And in between, we'll keep disturbing you, sir.
Absolutely. Anytime. I will share this presentation with Dr. Kalaivani, and all of you can take it from there. I'll also put it on some of the WhatsApp groups, which I'm sure many of you are members of, and you can use it the way you want it. Okay.
Yes,
I don't.
YouTube also, sir.
Sorry.
You have to hear it again
YouTube
and again,
also.
sir.
We'll put it on YouTube also. We'll do that. Okay.
Yes, sir.
Thank you.
All right. Dr.
Thank you,
Sridhar,
sir.
thank you and good evening.
Thank
and
you
good
very much,
night.
Dr. Lakshman. It was very good, excellent
Thank you. Thank you.
presentation.
Yeah.
I also learned something there, even though it was the old one.
Yeah.
This medical subject is so much, that one you can learn every day till you die.
Absolutely.
Never ending.
Absolutely.
Thank you very much, Dr. Lakshman.
Thank you. Good night. Good night, everybody.
Thank you, sir. Good night, sir.
I'll end the
Good
meeting
night.
now. Yeah.
Thank you, sir.
Okay,
Thanks
thank
to
you.
all the audience too. Thank you.
Yeah.
And thanks to my fellow colleagues. Thank you, sir.
Okay. Good night. Yeah.